I can't see yet. What I'd like to do briefly is to quite quickly go over the last presentation and see, in case there are people that are attending the webinar for the first time, they're getting the second part. I'd like to go over just the first part, maybe fill in some blanks for them if there are people that are seeing it for the first time. So what we talked about is this, this phenomena of understanding human interaction between us as professionals, licensed professionals, clinicians, and the client, and this phenomena of projection unification, which is when a client splits off part of themselves unconsciously and places that part onto you. We experience that through what we call interpersonal pressure that sometimes force us to react in ways based on what has been projected. So if a client has a part of themselves that is really, really upset and angry, they have this incredible keen ability to make us angry, and how they understand their anger is by us responding to them in an angry way. It's called acting as if in the object relations world, which is the modality of psychotherapy that I practice when I work with personality disorders. I think it's very, very effective, yet it's very complicated and at times difficult. So I think it's what I try to do is, for myself, I dumb it down so I can understand it. Most of you are probably beyond that level, but this is the way I can present it the easiest. Is what I encourage you guys to do when you're working with this level of pathology is to have an internal thermometer that you're able to be aware of, and that internal thermometer hopefully gradually begins to increase with emotion, but sometimes that thermometer goes from 0 to 100 very, very quickly. So try to remember that when a client is projecting some of their experiences on us, our emotional thermometer is very, very key in how we interact with that person. Common experiences are feelings of guilt. Now, this is what's being projected onto us in what we feel or begin to experience and what drives us to do certain things. We begin to have feelings of guilt for the client. Maybe we've grown up better than they have, and we feel somewhat upset or sad for them because of their life experience different from ours. A lot of therapists early on working with this level of pathology sometimes have fantasies of what we call rescue, which is typically we understand that there's conflict in development with people with borderline personality, and we want to reparent that particular person. What I would call kind of a smothering of emotion and wanting to hug their pathology out of them. Again, this is what's being projected onto us, and this is what we find ourselves doing, maybe sometimes without even thinking about it. If you've worked with this population, you certainly know that there's a level of rage and hatred we have at times for the person. And again, what's being projected onto us is a sense of rage or hatred for themselves that's being projected onto us. And then without realizing it, we hate them. And it's called completing the circuit, basically, in the object relations world. Sometimes we get helpless and we believe our clients are worthless. We have anxiety and terror. And this is something that's not talked about a lot, and I could probably do just a complete webinar, hour webinar in itself, and that's the erotic feelings and fantasy that therapists have with their clients based on projection. People with borderline personality typically, I'm not going to say 100%, but typically have been sexualized in one way, and it's a language that they're very comfortable with, and at times can elicit erotic feelings. Same sex, opposite sex doesn't really matter. They can activate erotic feelings in therapists, which will then change the way they approach that particular person. If you're into your license and you have availability to your particular board, and if you ever want to look at some of the action that goes on with therapists and the board, whether it be psychology or master's prepared, you will see a significant number of therapists that unfortunately have sexual relationships with their patients and get their license revoked because of it. And unfortunately, I've worked with several clinicians in the Jacksonville area in Florida who have had sexual relationships with their clients and have found out that, simply put, if they may have been educated on this phenomena of projection identification, they may have been able to stop that, but unfortunately, that behavior existed, and unfortunately, the board has no patience nor tolerance for it. So, in the state of Florida, it's automatic revocation. So, what do we do with this projection identification? When you're working with this level of pathology, whether it be in a group setting or an individual setting, you can't have off days, and we all have off days. I happen to have a very beautiful office that's on a golf course, and if I sit on one side of the room, I overlook it's really nice plush tee box. If I sit on the other side of the room, I don't see the golf course. So, being an avid golfer, what side of the room do you think I sit on? I am not facing the golf course because I can slip off and daydream with the best of them. Individuals with borderline personality are keenly aware of your interest in them, whether it be in a group environment or a session. So what do we do with phenomena of projection identification? We have the interest to want to parent, to protect, sometimes the wish to murder, and that's tongue-in-cheek, the wish to warn staff that we have, a borderline personality in the population, or believe it or not, the wish to have sex with. And what I'm talking about is the individual's, the therapist's individual experience that they may not be verbalizing to anyone. So this projection identification phenomena is eliciting these experiences in us that are typically outside the box. They're not normal reactions that we have. So what I suggest is that you stop yourself, you listen to this webinar, and maybe down the road, remember that the 4 letters of STOP are the way you can warn yourself that you're about to do something, what we call acting as if. So, for example, if you're a male therapist or a female therapist and you have a client with a borderline organization that dresses provocatively to session, and you find yourself beginning to fantasize what it would be like to be with that person sexually, you can get lost in that, and that can sometimes drive your therapy to make off comments, to offhanded comments, suggestive comments, flirtatious comments. And unfortunately, that person with that organization, that borderline organization, can be waiting for you when you go to your car at 7 o'clock at night and find yourself in a very uncomfortable situation. So what I'm suggesting is, through this phenomena and understanding of projection identification, realize that the individual is most likely unconsciously attempting to elicit these feelings. And then what happens is we act as if. We give those feelings and react to those feelings back to that particular person. So how do you know you're being projected upon? Best way is, if you're in a group environment, have somebody come in the group and co-facilitate for a little while, a couple sessions, couple groups, and let them give you feedback that hopefully you are receptive to on how you're interacting with this particular person in the group. I'm hoping that you don't have a full group of individuals with a borderline personality, but that may be the case. So one of the reasons or one of the symptoms of being projected upon is you begin to feel sorry for your client, maybe sorry about what she's experienced in her life, maybe sorry about her development, maybe sorry about the relationships she's had with parental objects. So we begin to give that person extra time and make her feel special. Key thing is make her feel special, because she didn't feel special growing up. So we feel the motivation to overcompensate for that. How do we do that? A lot of times we see in a group environment or an inpatient environment, we give that person extra reading time, extra dessert, extra smoke break. I joke and say an extra Klonopin, money for a bus ticket, money for cigarettes, things that you do outside of what you would normally do in your everyday world. You begin to get a sense that your client at times is worthless and untreatable. Or, unfortunately, in the slippery slope, you begin to flirt, and before you know it, find yourself in over your head. Those are all what I would call being victimized by projection identification and not understanding what's going on inside you and what's being projected upon you. What happens with somebody with a borderline personality are reenactments. Reenactments are basically dyads of experiences between her, i.e. self, and other people in her life, specifically parental objects, mother and father, or caretakers. So what's important working with somebody with a borderline personality is to constantly have a dialogue that is not what's being verbalized in session. So it's going to sound a bit strange, but bear with me. I joke on the golf course and say I have multiple voices in my head. So I have the voice that I have that represents my communication with my client. Then I have a voice that's behind that that's saying, I wonder what's going on right now, that represents a reenactment in her existence. So what part do I play? And we have to be aware of what role we play. So I'll give you an example of getting trapped into the phenomena of projected identification and how destructive it can be without realizing what's going on. So we have a client with a borderline organization and group. She's very needy. She's not getting her needs met. We feel obligated to go above and beyond. We give her some time after a group for individual stuff that's a little bit outside of the norm of the schedule. We begin to feel sorry for her, and we don't know why we have this overwhelming sense to want to hug and nurture. And so we give her $5 for a bus ticket, or $5 for maybe a pack of cigarettes. And we begin to realize that, or somebody on the staff begins to realize for us, that we're kind of overstepping our bounds. And we snap at that person who's pointing that out. But because we're good clinicians, we go back and all of a sudden now we're going to set boundaries with this person. Well, it's a little bit too late. You've already crossed the line. So what happens is when we try to set boundaries, we get, let's just say, an emotional storm or an affect storm. If I could cuss, I'd call it a shitstorm. So, but I can't. So if we are getting that shitstorm, we now have set it up by going above and beyond, attempting to nurture and hug out this person's dysphoric emotion. But then we often now have to say no, and that's incongruent to somebody with a borderline organization. So they projected this neediness onto us. We acted as if we're their parents. We parentify the relationship. We don't realize we're doing it, and then we have to say no, and it doesn't go over well. So it's one of the reasons why in addiction treatment, working with borderline personality can be so difficult. And I'm going to ask, if you are working in addiction treatment, to ask yourself, how much of a role does touch and hugging play in addiction treatment? And I know it's very common to hug in, whether it be support group meetings or it be meetings within the facility. But I wonder sometimes if you ever ask yourself what's behind that hug. What message are you attempting to send? But more importantly, how is that message or how is that hug being received? And with a client with a borderline organization who's been highly sexualized, hugging might be perceived differently than the message that you want to send. So touch can be a slippery slope working with borderline personality. So sliding into, no pun intended, by a show of hands, who here was available for the first presentation? If anyone raised their hand, that's really cool if you did, because obviously I can't see you. So if you raise your hand, good for you. You're following along in the presentation. And as you can tell, I'm a comedian looking for a job. So let's slide into, no pun intended, the second presentation. Working with borderline clients in treatment. It's common for some with borderline personality to not trust either the therapist or members in group. So how do we know a borderline who's entering, say, a group for the first time doesn't trust? Well, there's the obvious body language, looking down at the ground, not wanting to share, not wanting to talk about why they're there, being very quiet. So that response activates a lot of different things in the group. So a lot of the conversation for today is going to be about group, but obviously you can modify this to individual. And if you're in individual, or if you're in group, and I'm talking about individual, you can modify it for being in group. It's just, what happens a lot of times in the group environment is the person with a borderline personality sees not only the therapist as a potential threat, but now several group members are threatening to her. So the quick question is, why does somebody with a borderline organization not trust either the therapist or members in group? And if you saw the first presentation, the hint is remember previous presentation. So because you have those slides in front of you, I'll slip right to it. The answer is because we all represent possible reenactments that are painful experiences stored in memory. So what does that mean? Well, it's complicated. And I'm trying to make this sound as simple as possible. I know a lot of you out there are going, this is far from simple, and he's making it sound too simple. And you're right. What I hope to do through these two webinars is to activate enough interest to where you went on and studied or read some Otto Kernberg, some Gunderson, some people that I think that write, at least at my level, IQ level, about 102, I think, tested. We can understand why it's so complicated to work with somebody with a borderline personality. So the answer is obviously because we all represent reenactment or possible reenactments that are painful. So borderlines, no matter how they appear, are fearful of countless experiences of rejection and abandonment. So what do we normally see in a group environment or an individual environment, more importantly in the group environment? Borderline does not appear fearful of rejection or abandonment. As a matter of fact, she feels what? Usually the other side. There's a heavy overcompensation, and she's cocky and arrogant and flippant and wants a challenge. And so the question is, no matter how they appear, internally, they're extremely fearful that sooner or later, whether it be people in the group or the therapist or the facility, are going to reject and abandon them. So I ask therapists, professionals to ask themselves, so why shouldn't this happen now? Why shouldn't somebody coming into group not expect to be rejected or abandoned? So if you are in a group environment, and one of the difficulties I think with, and this is just my own pontification, but one of the difficulties we have in drug treatment is that it is a heterogeneous environment and not a homogeneous environment, meaning that there are not many facilities that, let's just say, treat borderline personality who also suffer from addictive disorders. So imagine in a perfect world, 10 individuals who have a borderline personality and a cocaine problem. That's the perfect clinical world. Why? Because everybody suffers from the same phenomena. The problem is, because of managed care, and let's be honest, it's difficult to do that, we have more of a heterogeneous environment, which is individuals may have a bipolar disorder and a substance use disorder or pure substance abuse disorder, which we don't really see a whole lot of. Usually there's comorbidity for coexisting diagnosis, but we have a stew, no pun intended, but in parentheses, STEW, a stew of individuals with problems. So the individual with a borderline personality is going to react to that stew. Individuals with a borderline personality are going to sense, yes, the group is accepting right now, yes, my therapist likes me, but sooner or later, it's going to come down to me being rejected. It's going to happen. This is an internal belief system that is based on hundreds, if not thousands, of individual dyads of experiences in this person's life that result in rejection and abandonment. So in a sense, they come in thinking that, well, this is all nice, it's going to happen sooner or later. So one of the biggest mistakes that I've seen, and I've made this mistake 1,000 times, but one of the biggest mistakes I see that is along the spectrum of projection identification is that they at times force us to disclose personal parts of our life. Now, there's a lot of school of thought regarding disclosure. In my supervision and in my reading and my training, I was taught that for every 10 times that you want to self-disclose, 1 time may be appropriate. Maybe. So it's actually less than 1 time out of 10 that self-disclosure is appropriate. However, if you have somebody with a severe personality disorder, specifically a borderline personality, they are going to, through the phenomena of projection identification, they're going to get us to self-disclose. So what happens when we self-disclose? Well, we'll go into that for a second, but let's look at what self-disclosure truly is. Self-disclosure is supposed to, in a perfect clinical world, be about the client. Unfortunately, in the areas I've self-disclosed is at times I've told clients I've got twin 6-year-old boys. I tell them where they go to high school. They go to a college prep high school. They don't have my IQ. I've talked, obviously, I've got golf. I've got golf trophies and pictures and hockey pictures all over both of my offices. So I'm disclosing parts of my interests. Interesting enough, a lot of individuals with a borderline personality will find something interesting to connect with my interests. And before you know it, my self-disclosure is more about me and it has nothing to do with them. However, they like to use it. So I ask therapists and participants, professionals working in a group environment, what is the baseline of the self-disclosure? Are you doing it for yourself? And that's difficult to admit to because we always think what we're doing is always beneficial for the client. So we have this borderline personality disorder patient who is really interested in us personally. But how do we handle that? And think of an experience maybe where you felt compelled or forced, or I'll even go as far as saying trapped to self-disclose. And I just ask that you bring those experiences up and just remember them. We'll talk about it in a second. So this next portion of the slide is, hey, if we have to do it, why not you? So in other words, I'm not finding myself self-disclosing with other patients in group, and I find myself being able to set limitations, and I've got ways to not self-disclose, but for some reason I'm compelled or somehow driven or I'm rationalizing self-disclosure to this borderline patient. So I go back to some of the experiences that we feel when we're projected upon. We feel sorry. So we're trying to get this person connected to group. So I'm talking about my interest in golf, and I'm talking about my interest in hockey. And other people in the group are talking about their interest in golf, interest in hockey. And that's all great. But what a borderline experiences is power over the therapist if they can get the therapist to self-disclose. And guess what? When a person with a borderline personality perceives that they have power over the therapist, there's a power differential, and it could, I'm not saying it will, but it most likely ends up with not a good experience for both staff and for the person with the borderline organization. So there's a statement called clinical honesty. Personal disclosure versus clinical honesty. Based on our desire to look normal, to be honest, to tell clients, I was there one time, I feel your pain, I had a screwed up childhood. There's a desire to want to disclose to help the patient connect. The problem is, and there are several out there that will argue with this, and I'll probably receive feedback that I don't know what I'm talking about, and that's okay, because I may not be knowing what I'm talking about. But in reality, personal disclosure is normally exploited by somebody with a borderline personality. So I'll give you an example. Let's say that in a one-on-one session after group, the individual with a borderline organization entices me into talking about my sex life. And I do that, thinking that I'm somehow helping and thinking that it's totally appropriate. So unfortunately, stuff happens in treatment, and let's just say that our client has used substance and she's getting discharged because she's seen as not ready for treatment and she's being kicked out of the facility. So on the way out, what do you think she tells administration? She says, well, my therapist talked about his sex life. I think he was hitting on me. I'm going to file a complaint against the facility and against his license. So your admin staff or your HR staff sit you down and say, this is what the client's saying. Well, we all get defensive. We all say, no, that didn't happen. She misinterpreted. She took it the wrong way. But if there's a videotape or an audio tape, it would show that, no, we did. We did get sucked in, and we did talk about our sex life, and maybe we were aroused by it. That's personal disclosure. I come from the school of thought that is totally inappropriate. However, you're not going to get an A++ on this. You're going to make mistakes. I've made some of the mistakes. I don't want to waste your time on it over the 20+ years of working with this population. But I'm asking you to look at this phenomenon called clinical honesty. That's different than personal disclosure. keyword here being clinical honesty. So we have a desire to look normal, to be honest, because of this fear, this power differential that clients sometimes put us on as therapists. And then we sometimes try to overcompensate and show that we're just as normal and just, maybe as messed up as they were or are sometimes. So a lot of therapists who work in addiction treatment are in recovery, and personal disclosure is extremely important. And I'm not here to argue whether that's appropriate, effective, or not. All I'm trying to do is show you and have you question your desires at a time when you're working with somebody with a borderline organization, because it can be very, very complicated. So we share personal information that will most likely come back to haunt us by the use of what we call double binds. Double binds are these lovely damned if we do, damned if we don't. So when a client sits you down, when you sit down with a client and you're assessing them for group, and they ask you, are you in recovery, or have you ever had problems with substances? This is an actual experience I had with a borderline personality. If I were to say, yes, I am in recovery, they say, see, you know better than me. And I go, well, no, I'm not. Then they say, how can you help me? And I say, it's none of your business. And they say, see, you help me, you hate me. That happens within about 25 seconds. They storm out of your office and you go, how in the hell did that happen? So yes, I am in recovery. And they say, see, you know better than me. And I get defensive and say, no, I'm not. And they say, well, then how can you help me? And I go, I don't know. It's none of your business. It's secret. I made special potions called psychotherapy. And then go, see, you hate me. And you walk away going, how in the hell did that happen? Personal disclosure rarely is effective in helping someone with borderline personality disorder integrate into therapy. Now, I know that there may be some DBT fans out there, and we all know that Marshall Linehan did a extended article in the New York Times and self-disclosed about some of her personal struggles and development and the fact that she was hospitalized and things. And I personally, while I think that may have helped some people, I actually think that was a setback for us. And I know that could be a debatable topic and a controversial topic, but I think that goes into the line of personal disclosure versus clinical honesty. Clinical honesty is a way to relate to the client in the here and now by letting her know what it's like to be with her in the present, and more importantly, if anyone else in the group may feel itself the same way. So if you do group, and I've done probably over 4,000 hours of group, some of the challenges are getting group members involved and active and not being the sole focus of group. Sometimes the facilitator becomes what I call the lecturer, where everything goes through the therapist, versus a good working group, as you know, is the therapist that sits back and kind of keeps the group moving in the right direction. So if you are a group facilitator or a group therapist, remember the group is a small representation of a subsection of life, and more important, the client's life. A nuclear and extended family is a subsection of groups. So commonly, if a person in borderline personality comes in and creates chaos in the group, well, guess what she does when she leaves treatment and goes home? She creates chaos. More importantly, what do you think she does when she goes to her first AA meeting? She creates chaos. So group, as you know, is a microcosm of the individual's personal life and their personal experience and their family life. So what I'm suggesting, and this is not easy to do, and I just suggest that you be aware of it, is instead of answering direct questions with direct answers, we go to the next slide. And that is that we find a way to show what it's like to be asked that question. We find the client a way to show what it's like to be asked that question. So when a client says, are you in recovery? Have you been diagnosed with a borderline personality? And I get that a lot, believe it or not. Why have you dedicated 20 plus years of your professional life working with borderline personality? Do you have borderline personality? Was your mother borderline? Was your wife borderline? If I get trapped into that question, I can give her a concrete answer, yes, no. But what's more important is helping the person understand what's going on in the present. So an answer would be, you seem to be interested in knowing whether I can help you or not, and by doing so, you challenge me. I wonder what happens in your life when you challenge those close to you. How do you think it goes over with somebody with a borderline organization who's challenged her parental objects in life? We can probably guess it's not going over very well. So what is that particular person, what's that patient doing for you when she's challenging you? She's checking to see if she's going to get rejected and abandoned like she did when she challenged her parents. So again, I'm going to go back to that topic of there having to be two voices in your head. There's a voice going on with your patient in your interactions, but there's also the voice in the back of your head going, what am I representing to this client right now? So instead of, again, answering the question directly, you tie what she's doing, the challenging, and link it to her conflict with others and open the possibility of why she may be rejected by others so quickly. That's a mouthful, and that's a 2-hour webinar in itself, but I'm going to slow it down again. So instead of answering the question directly, you think about it and you tie what she's doing, the challenge, and try to link it to her conflict with the other objects in her life, i.e. these other dynamics with particularly mother or father, where by her challenging them early in life, she ended up getting rejected. Maybe because of her parents' temperament, maybe because of her parents' substance use. So basically what you say something along the lines of, I'm going to guess that in the past you've challenged, but it didn't work out for you. In other words, in parentheses, you got rejected by others because you were so challenging so quickly. So what I encourage a client to do, and again, I don't give her the answer that she's looking for, but I just say something along the lines of, I wonder what happens in your life with others when you become demanding to know what you'd expect and it doesn't work out for you. I personally, and this is my own taste, I don't use the words rejection and abandonment in treatment. I know it's there, they know it's there, but I don't feel the need to have to say something along the lines of, let me guess, this is a double bind. If I answer, it's not going to work out. If I don't answer, it's not going to work out, and you're going to feel rejected or abandoned. At times early on in treatment, I think that term is too raw. I think over time, once it becomes desensitized, it's totally appropriate to use. But early on, I think at times it's just too raw and it can turn a client off. So more important, it's not what she's saying, but how she's saying it that sets her up for rejection. So I have this theory, I don't have time to study it or to measure it, but if you think about the way relationships are going now in 2019, 2020, I'll give you an example. I walked by one of my son's bedrooms the other day and he was frantically texting. And I said, who are you texting? He said, well, it's his girlfriend. And I kind of, believe it or not, I can be a little flippant, and I said, why don't you call her? And he went, that's so old school. Think about that. They're going to be 17 in a couple of weeks. This is the transition generationally of where communication is going. I don't know if you've ever noticed in your own texting with your significant other, but I'll give you an example of mine. Hey, I'd like to play golf both Saturday and Sunday. And I get a response, fine. But it can also be fine. And it can also be fine. Same 4 letters, 3 different distinctive interpretations. Individuals with borderline personality have problems with interpretation. So it's important to help her realize that it's not the syntax, it's not the words that she's using or saying, but how she says it results in her getting rejected. That's not an easy challenge to take on. So obviously you're not, and this can be a trap, you're not, I don't think you're in a position to treat the borderline organization when she's in a group environment for a cocaine problem or a methamphetamine problem or a drinking problem. So how do we work with the personality organization and not treat it? This is different than actually treating it. So how would I treat it would be totally different than how we're going to try to facilitate this organization in a group environment. So when an individual with a borderline personality wants you to self-disclose, I ask you to stop and to ask yourself, what's going on here? Is she setting me up for a trap? So let's, again, go to, I do self-disclose. No, I'm working in addiction treatment. I'm not in recovery. As a matter of fact, I hate addicts and alcoholics. I'm just waiting to get licensed so I can go on and do the work that I want to do. How do you think somebody with borderline personality reacts to that? Again, putting in the double bind of, gee, I feel compelled to answer a question, because if I don't, it's not going to be a good experience. Dan if you do, Dan if you don't, is one of the worst experiences a therapist can experience with a borderline personality, because we're trapped. So in a group environment, and I'll shift back to a group environment, obviously we encourage self-disclosure with regards to other attendees and participants and their substance use, where they are maybe in the Prochaska stages of change with their addiction. It's all kinds of things we want the group to be talking about. But if you notice, an individual with a borderline personality will sit back and will ask for what I would call maybe inappropriate personal information. And what that is a setup for her to get rejected. So how do you deal with that? It's not easy. Please be advised that when you delve into this area of repressed affect, you're most likely going to experience what I call in the slide a storm of emotion. What I'm going to suggest to you is a shitstorm. That there is going to be a decompensation that is going to be very difficult to help tolerate in a group environment. So what happens in a group environment? What usually happens is what we commonly known as splitting. Splitting has its what I call simplistic surface level definition, and then it has a much deeper interpretation, or a different, much deeper definition, is I guess what I'm trying to say. So what do we observe when we look at somebody who's splitting? Well, have you ever had a patient who did not get what they wanted and demanded a million meeting? They wanted all the patients at one time to sit in with the medical director, because they're going to give the medical director a piece of their mind about how they're being treated on the milieu or on the floor. So here's a classic example. Later on at night, everyone's gone home, nursing staff is about as thin as you can get, and the borderline who's got maybe Klonopin PRN for agitation goes up to the nurse and says, I want a Klonopin. And the nurse says, well, what's going on? I want a Klonopin. And the nurse goes, well, in her head she's saying, well, I think you're drug seeking. Maybe you could try to tolerate what's going on without the use of Klonopin. As we spoke of in the earlier webinar, what's the deciding factor? Let me rephrase that. What do you think is a word that somebody with a borderline personality has great difficulty tolerating? Somebody in the back is yelling out, no, and they're accurate. Individuals with a borderline personality do not like and react to the word no. Well, why is that? Well, it's believed, at least theoretically, that a lot of people with a borderline organization have heard the word no in lieu of getting nurturance and support and emotional support. So guess what happens? They split the group up, right, into maybe two different parts. Half the people love the person with the borderline personality. They're on her side. They think she means well. And the other half hate the individual. They're going to the therapist. They're going to the medical director saying, you got to get rid of her. She's doing all this different stuff. And as a therapist, you find yourself going, maybe I have to go work at the soup kitchen for a little while until she leaves. So what do we do with splitting? We create a safe environment within the group. we help identify who is on what side. Now, there has to be a little bit of cajoling and some nurturance with this. I would suggest that you not come out and say, okay, who's on Susie's team and who's against her? I wouldn't suggest you take that line of action. I would look at, as a process, what's going on and notice that there's a split in the group. Typically, that represents the split between love and hate. So in an individual environment, you see splitting normally between the therapist and if there's a psychiatrist involved or if there are parents involved. So what do you see in an individual environment? You see the patient come in and say, well, I talked to my doctor and he says he's willing to give me as much Xanax as I want and he really doesn't care what you say. So there. Or my parents won't let me use my phone when we get into a fight and I want you to call them. Again, these are examples of double binds. In a group environment, what you see typically is, tell me if I'm wrong, individuals that hate the person with the borderline personality, and then the other individuals who are significantly attached to her and want to help her and feel sorry for her and want to rescue her. So I talk about the difference between listening and hearing. So what's the difference? I believe, working with borderline personality, that the phenomenon of hearing is the noise that they're making in our ears, which is our catcher's gloves, are picking up that particular noise. And unless you're deaf, you have to hear. The important piece is listening, which can be very, very difficult working with a borderline personality who's agitated and who is agitating us. It's really difficult to listen when we're agitated. So going back to the original couple of slides, we use our interpersonal thermometer, and we notice that our thermometer is elevated. So we have to use whatever techniques we employ to get ourselves under control, whether it be deep breathing, whether it be some mantra through our head, through self-talk. Whatever we do, we have to regulate our emotion, get our emotion back in check so we're not reacting emotionally. And then we have to listen. And we have to educate the group, it is a group environment, about what we call emotional listening. And what is emotional listening? Emotional listening is when we listen emotionally. Duh, no kidding. But what that suggests is that our interpretations are being so influenced by our emotional state that the interpretation becomes irrational. So if I'm angry, it's really difficult to think happy thoughts when you're angry. So if one is angry, we have to teach the group the difference between listening versus hearing, and then point out what emotional listening is. So when you have somebody with a borderline personality in a group environment, you can't come out and say, okay, we have a borderline group, we're going to all have to be able to monitor our emotional state. No, what we do is we say, you know what, group is a microcosm of society, so when you leave here, whether you go to a meeting, whether you go to a halfway house, whether you go back to the condo, whether you go back to school, you're going to be in a group environment where people have different personalities and different problems. So let's use this skill so we can use it when we leave here. If you are agitated or if you are amped up emotionally, I suggest that you use whatever skill set you teach in group to get the person and their emotional state down a little bit so they can listen clearer to what is being said. So an example of that would be the person with the borderline organization is saying, you all hate me, you want me all to leave. Well, if you get into that agitated state and you're going, yes, we do want you to leave, yes, you're too sick for here. You lower that agitation state using your own techniques. What are you hearing? I'm fearful that you're going to reject me, which is usually her core belief coming into, if you're going to use a CBT model, it's her core belief coming into a treatment environment. So helping the group listen emotionally, in other words, get rid of the emotion, get it down, and listen closely to what the person is saying, keeps splitting down to a dull roar. The problem is we take sides. And by taking sides, especially as a therapist, which I think can be one of the worst mistakes that we make in a group environment, is taking sides. Let's say the person with a borderline organization gets into a heated debate with somebody about whether they meet criteria for a severe substance use disorder. And you decide, for whatever reason, typically because of the projection identification problem, you want to either try to nurture the borderline and protect her, or you want to throw her out to the wolves and say, no, you do have a severe substance use disorder. When you take sides, I'm going to suggest you look at it as getting caught up in the transference, countertransference phenomena. And that, I believe, is not only extremely unhealthy for the client, but it's also unhealthy for the group, because our job in the group environment is to facilitate the process. That's why I like the Prochaska model really well, or the motivational interviewing model really well, because you find the patient where they're at and you address where they're at, and it's not a, I call it a litigious experience. It's not a power struggle. It's just, hey, you don't believe you have a problem? There are people in here that have data that suggests otherwise. Let's listen to what they have to say. So I'm going to ask you this question, is that when you take sides in the group, does it feel good? And I'm going to ask another question that you ask yourself, if it does feel good, to ask yourself, do I have a right to be in this battle? And if you answer those questions yes, I would suggest that you are stuck in the projection identification process. And it is not helpful. The end result is the group gets stuck, you get stuck. So it's a little bit confusing. It's been difficult for me to kind of normalize this, because of most of my work is done in individual environments, but I have done a lot in a group environment with people with BPD. So in summary, individuals with severe personality conflict, to try even the best therapists as patients, no pun intended. Based on this simple yet complicated procedure of projection identification, if you don't know it's happening, it's the main reason why group turns into a frenzy. I even come from the school of thought of trying to educate group members, if we have somebody with a severe personality disorder, such as a borderline personality, educate the group members on what happens in the projection identification process, so they don't get so activated and the group can stay on task. The key thing is to do a really good evaluation, and unfortunately, working in the substance abuse environment does not allow that sometimes. You go into close relationship dyads, and I'm currently supervising somebody, and he doesn't know this yet, but I'm going to suggest that he spend an hour with a new client just talking about the relationship he has with his mother, and then spending another hour with the client talking about their relationship with their mother. Think about that. Can you spend an hour digging information, asking about reactions, asking about being loved, about being rejected, what was it like, did you feel close, did not feel close, and all these other questions, so we get a picture of this dyad between this very early object in an individual's life. An hour is a stretch. I've challenged myself. I sometimes can only get to about 35 minutes, and that's pushing it. So 60 straight minutes. And while you're doing that, I suggest that you listen for a theme in those relationships. Typically, the theme is some level of mistreatment. Mistreatment, there's a spectrum of mistreatment. Mistreatment, if you talk to my sons, is sometimes not getting what they want on Friday night. Some individuals you'll see on Friday night, or honestly, some individuals you hear about mistreatment being that I don't see my parents for 3 or 4 days, and there's no food in the refrigerator. And I had to go and steal from the local store. And when I got home, my mother was so high on crack cocaine, she would beat me until I fell asleep. So there's a spectrum of mistreatment. So I would encourage you to spend a lot of time, if you have the opportunity, on these early relationships in these, what we call these dyads. Not only how she was treated, and how she reacted to the treatment. Because what you're going to commonly see if you set up this called setting the frame, you're going to see this is a reaction that she's going to have towards you, whether it be an individual environment or group environment. So it's important to learn to ground those who can't regulate their emotions. Sometimes we think mood stabilizers or benzodiazepines are good grounders, and they may be, depending on that person's ability to not abuse. But if they're not able to stay away from abusing those substances or those medications, then we have to use a different skill set to ground. I think the DBT skill set training book is very, very good for teaching individuals grounding techniques. Working with DID, I can tell you that sometimes the grounding techniques sound spectacular, but they're not really effective. I suggest that if you're going to help someone ground, you help them use their 5 senses. And that is, I could list them to you right now under pressure, but burning a candle, holding on to an ice cube, holding on to putty, having them feel their feet on the ground. De-escalates typically anger very, very quickly. So in a group environment, if you're going to try to do this kind of work with somebody that has a documented borderline personality, not just someone that pisses you off, not just someone that's difficult, but maybe through an MMPI or PAI or some of the object relations instruments that we use to rule in or rule out a borderline personality. If you really have somebody in group with a borderline personality, or God forbid if you have more than one, if you have 2, you have to be very aware of this phenomena of projection identification and splitting. And warding it off is extremely important if you have any interest in getting that person connected to spiritual life, a recovery life, or a support group system. So let me just speak for a minute or two about that. I know a lot of facilities send people out to AA, NA, Smart Recovery, or any other self-help group as per their treatment. With somebody with a borderline personality, I think it's extremely important to ask about their reaction and what it was like to be in that particular meeting. Why is that important? Well, I believe a meeting is a microcosm of a person's life also. So not only do you have them in a microcosm of life in group, but you also have them in a microcosm of their life and a meeting. And guess what happens after about the second week? The person with the borderline personality begins to have erotic projection identification experiences with people in meetings, or she begins to have real angry reactions, which represents the dyads in her early life. They have to be addressed as part of the addiction treatment. If not, unfortunately, the success rate is not really high with BPD and substances. Unfortunately, if these issues are not addressed in treatment, the person leaves, goes back into a recovery environment, and reenacts those either erotic sexual transferences or this angry dyad with an object, mom or dad. And then they typically stop going to meetings. Unfortunately, they relapse and they move back into your facility a couple of weeks to a month down the road. So I'm encouraging you to take the opportunity to try to head that off at the pass. Please remember something and help staff remember this in closing. Please remember that they may be responding to us or they may be responding to other. And if you remember my early description of self and other, and we talked about the Tom Hanks movie, Castaway. First couple weeks to a month that Tom Hanks was on that island, he was digressing back to a psychotic state. He was losing touch with reality. He lost touch with, in quotations, other. What he did, interesting enough, it's the volleyball that I played with when I played beach volleyball when I was most of your ages. He found that volleyball washed up from the wreckage, and that became other, a representation of somebody else in his life. And the joke is, well, he talked to it, it talked back, but that volleyball represented other to him, and his psychosis stabilized. You represent other to that person with the borderline personality. And if you want to help this person, you have to be aware of their early reenactments, because you can find yourself trapped in acting as if you are the emotionally restricted mother or the physically abusive father. That's a mouthful. That's a lot of information. I most likely confused the heck out of you, because I tried to cover probably a full 16-hour conference in 2 one-hour webinars, but I did my best, and hopefully I helped you motivate yourself to do some reading on this. Any questions?
If you do have questions, please go ahead and put them in the question box, and we'll try to get those answered in the next minute or so. All right. We don't have any questions, so thank you, Michael, for presenting on personality disorders. We really learned a lot, like you said. And thank you, everybody, for joining us on the webinar today. Really appreciate you taking the time to come together and learn with us. Have a great day, and I hope that you will watch your inboxes for the post-test and the evaluation so that you can complete those. Let us know how we're doing and what we can do in the future. And we'll see you back here in August for the next webinar. Have a great afternoon.
It's the good one.
Yes.